Rechallenge with immune checkpoint inhibition, yes or no? We talked in the session about cross-resistance between the two, potentially, because the payload seemed to be driving cross-resistance, not the target. Would you sequence EV after DV? And if you were not going to do that, what is the standard of care currently?
So I think at this point we have really insufficient data to advise to switch from EV to DV or the other way around. I think, well, basically for any treatment we lack data, but I think the most logical in this situation is to give second-line platinum chemotherapy, and I think in trials that we will be doing, that should be the standard arm for trials. So I think that's what I would stick to. I can imagine that, you know, in the end, my feeling says it's more chemo resistant that develops, but even there we don't have enough data. But you know, I think in later lines, if you've given a couple of other lines and would want to give it a go at that point, I think maybe that would be reasonable. But at this point, we really lack the data to recommend giving the same.
Is it still the case that you get one good go at bladder cancer? And
absolutely.
Still the case to use your best treatments first?
I think that what we're seeing here, and what we'll talk about later lines, but really the jackpot for a metastatic urothelial cancer patient is long-term remission and perhaps cure, which I do personally believe in, and I think that we can reach that potentially in about a third of patients. I think that's the number that we really should focus a bit more on, that we can raise that number, because that's really what patients are looking for.
I want a quick yes or no answer from both of you. Rechallenge with immune checkpoint inhibition, yes or no?
No.
In principle, no, only in very, very select cases.